Hello everyone and welcome back to Clinical Cousins YouTube channel, where today we're going to go over the various waves, segments, and intervals of the EKG and their clinical importance. We'll begin with the P wave. So we know that the P wave represents the depolarization of the SA node, the internodal tracts, the Bachmann bundle, which is located in between the atria, and the atrial myocytes. Basically, it represents the depolarization of the entire top half of the heart. So the normal P wave duration, or how long it should be, is 0.08 to 0.11 seconds. Or think of it as greater than 2 small boxes, but less than 3 small boxes. A quick aside is that the TP wave represents the repolarization of the atria, and it looks like the opposite or negative deflection of the P wave. However, the electrical view of this TP wave is usually overshadowed by the great QRS electrical activity. So, if your patient has severe tachycardia, which we know will shorten this whole complex and move the QRS over here, you may see this TP wave, and it may appear as ST segment depression, although it is not true ST segment depression. It is really just the repolarization of the atria. So now we come to the PR segment. Remember, segments are measured in height. So the PR segment is from the end of the P wave to the beginning of the QRS complex. We remember that the PR segment represents conduction through that isoelectric AV node. So the thing that we must remember about the PR segment, not the PR interval, the PR segment, is that it must be depressed no more than 0.8 millimeters. So remember, one small box is 1 millimeter tall. So an easy way to remember this is that the PR segment should not be deeper than a little less than 1 small box. So again, the PR segment should not be deeper than 0.8 millimeters. So let's say that your patient has a PR segment that is depressed to 1.5 millimeters. What is the likely cause? The likely cause that we have to memorize is that it is likely either pericarditis or an atrial infarct. So although these are more rare, they can happen, and you will catch them because you know that your patients will have a PR segment that is depressed more than 0.8 millimeters. So next we're going to talk about the PR interval, which is measured in time. It runs from the beginning of the P wave to the beginning of the QRS complex, and it represents atrial depolarization and conduction through that isoelectric AV node. A very, very, very important fact to know that you will need to know for the rest of your life is that the PR interval is normally between 0.12 and 0.20 seconds long. Any less, and we say that the PR interval is shortened, and any longer, we say that there is some degree of an AV block, which we will talk about the different types of AV blocks in a later video. So now we make it to the big mighty complex, the big QRS. The QRS, as we already know, represents the 3 parts of ventricular depolarization, right? And the QRS is normally has a duration between 0.06 and 0.11 seconds. Now, the Q wave can either be a benign or harmless good Q wave, or it can be pathologic. A normal Q wave is short and short. It's less than 0.03 seconds, and it is less than 1/3 of the height of the R complex. Therefore, if I gave you a patient who had a Q wave that was wider than 0.03 seconds and was deeper than 1/3 of the R wave height, you would say that that patient has pathologic Q waves. So a normal Q, or a good boy Q, is short and short, meaning that it has a short duration of less than 0.03 seconds and a short height, or less than 1/3 of the height of the R complex. So next we have something really, really cool called the intrinsicoid deflection, which is just a fancy way of telling us how fast the ventricles depolarize from the endocardium to the epicardium. So we measure the intrinsicoid deflection from the beginning of the R wave to the peak of the R wave. So an analogy that I like to use is The R stands for Rocky. Everyone knows Rocky Balboa. Even if you haven't seen the movie, you know that Rocky, he runs up that big hill. He runs up those steps. So think of Rocky as running up our R wave. If the right ventricle Rocky is in shape, this deflection will be less than 0.035 seconds and leads V1 and V2. And if the left ventricle Rocky is in shape, this deflection will be less than 0.045 seconds and leads V5 and V6. Okay, that was a lot, but let's remember that V1 and V2 are looking more at the right ventricle, and that V5 and V6 are looking more at the left ventricle. So now is your time to ask me, but Christian, why is this important? Why are you teaching us these nonsense things? They don't make any sense. They're never going to help me. Trust me, this can be very, very helpful, and I'll tell you why. Because let's say that our Rocky, he's been hitting the gym, and he's been hitting the gym hard. He's been going up. He's been doing a lot of resistance exercises, and he's put on 80 pounds of muscle. So Rocky's going to be strong, but he's going to be very, very slow. So let's say that his intrinsicoid deflection is, say, 0.055 seconds and leads V1 and V2. We would say that this right ventricle is likely hypertrophied, or it has put on too much muscle. The same applies for the left ventricle. The left ventricle hypertrophy is more common because in America we have hypertension. The left heart has to work more to put up with the high blood pressure, and it has to get bigger and thicker and stronger. So let's say that the intrinsicoid deflection is greater than 0.045 seconds and leads V5 and V6. This would mean that there is likely a left ventricular hypertrophy. So now let's look at the ST segment, which runs from the end of the QRS, also called the J point, to the beginning of the T wave. Now this is one of the most important segments because this will tell us if our patient has had an acute myocardial injury or even a possible infarction, commonly known as a heart attack. So the ST segment in our limb leads, remember limb leads are 1, 2, 3, AVR, AVL, and AVF, should be no more or less than 1 millimeter or one small box from the baseline. In our limb leads, the ST segment should not deviate more than one small box. So for the precordial leads, or leads V1 through V6, the ST segment should be no more or less than 3 millimeters from the baseline. Remember, ST precordial leads no more than 3. ST precordial leads no more than 3. So the golden rule for the ST segment is that if your patient is experiencing any cardiac symptoms besides a broken heart and has any ST abnormality, remember, limb leads that's greater than 1 millimeter, precordial leads that's greater or less than 3 millimeters, you have to treat it as an ST elevated MI or a STEMI, also known as a serious heart attack until proven otherwise. So basically, assume the worst if your patient is symptomatic and has any ST abnormality. For example, if your patient with shortness of breath and chest pain has an ST elevation of 4.5 millimeters and leads V3 and V4, we will suspect an anterior infarction until proven otherwise. So now let us look at our T wave. It represents ventricular repolarization from the apex epicardium to the endocardium, and it begins after this ST segment. The golden rule of T is that the T wave should be the same deflection as the QRS complex, meaning if the QRS complex is more positive, then so should the T wave. So the T wave must be a positive deflection if our QRS is positive. However, we must know that our T wave is a little funny. It is actually lopsided, and it's supposed to be this way. So the way we check if our T wave is looking good or not is we drop a stake in it. So imagine our T wave is a pile of dirt. What we do is we drop a stake in it, and if it looks lopsided to the right, meaning there's more green on the right side over here, that's a good thing. If our T waves look symmetrical, then we have a pathological problem. our T wave should not be symmetrical. So, from the beginning of the Q wave to the end of the T, we have what is called the QT interval. It is, I do not doubt that you guys have heard this before. There's drugs that prolong the QT interval, and it's very important that we know a lot about the QT interval. And I'll explain why in just a second. But we need to know that it is normally 0.40 to 0.44 seconds long. This is about 2 big boxes. And the thing is, the thing that will scare any cardiologist or any person who has any experience dealing with hearts is if you prolong the QT interval enough, it can eventually lead to a fatal heart rhythm called torsades, meaning twisting of the points. So this long QT interval can be caused by genetic mutations, electrolyte imbalances like hypocalcemia and hypomagnesemia, and even certain medications. So how do we know if our QT interval is safe? So the QT interval should be half of the normal R to R interval. Meaning, if the R to R interval is 1 second, then the QT interval should be less than 0.5 seconds, or half a second. This means that it should be about 0.40 to 0.44 seconds. Now, we also know that the QT interval can vary greatly with the heart rate. So it can be hard to precisely calculate, so we had to come up with some way to correct the QT interval for heart rate. This is why we call it the QTC. What is the QT being corrected for? It's being corrected for heart rate. So the formula for calculating the QTC is as follows. It is the QT plus 1.75 times the ventricular rate minus 60. And not that you need to know this, because the EKG machine will likely do this for us, but it is a good thing to know in case you have to do it manually on your own. But what we need to know is that the QTC is considered prolonged if it has a value greater than 0.419. So I know this is a weird number to memorize, but we must know it, because if it is greater than 0.419, we say that the corrected QT interval is prolonged. And remember, this puts us at risk for torsades, or twisting of the points. So lastly, we've come to our U wave. It comes after the T wave and before the P wave, and it is a long and slightly positive deflection. It can really only be seen in bradycardia and hypokalemia. Think that the U wave is usually when our blood potassium is under the normal levels. U is potassium under normal. So the good thing is that if we see that our patient has a U wave, then it is not possible for them to have hyperkalemia. So if you're worried about your patient having hyperkalemia, you see a U wave, you know that your patient, he's good. He's not going to have that hyperkalemia anymore, but we do have to watch out for hypokalemia, or low blood potassium. So lastly, about the U wave, please remember that the EKG machine, it can interpret the U wave as part of the QT interval. So basically it'll think that the QT interval is right out here. So before you run and you stick your patients in the jugular veins with calcium and magnesium, just go and manually check the corrected QT interval to make sure that the EKG machine is not picking up that U wave. So I know this was a long video. I'm hoping that you guys learned a lot. Thank you for taking the time to learn with us, and remember to like and subscribe for more content.